So we were talking about arterial blood from the neonate, and yes, you can cannulate the umbilical stump up to 48 hours after birth. And the picture, remember me telling you the picture is wrong, because after birth, the umbilical arteries will have oxygenated blood flowing to them, because that's a branch off of the femoral artery, internal iliac artery, is the umbilical artery. So it would have arterial blood. So the picture is not correct, but there are two arteries and one vein. The thing that I didn't ask you, I don't know, maybe I did ask you this question during lecture. If you're drawing blood from the umbilical artery, is that considered pre-ductal or post-ductal blood?
Isn't it post-ductal?
Very good, yes. So drawing from the umbilical artery is post-ductal. So if there's any shunting going on, you're going to get what the oxygen level is from including the shunted blood. So post-ductal. What about the right radial artery? Is that pre-ductal or post-ductal?
Pre-ductal.
Very good. So drawing from the right radial artery is blood that's coming directly from the left ventricle, doesn't have any shunted blood mixed with it. So it'll be a true reading of blood that came from the lungs and made it to the left ventricle. So that's pre-ductal. And I think that was all I wanted to mention that I didn't mention the last time. We talked about all of this. I think we talked about capillary blood gases also. And when you're drawing a capillary blood gas, it's a mixture of arterial and venous blood. And the results will vary depending on whether it's a full-term gestation, premature. It varies depending on whether you have Broward Health, Joe DiMaggio. So what I'm giving you are normals, like NBRC kind of normals for a capillary blood gas. And the pH will be in normal range, but it'll be the acidotic side of normal, so 7.35. CO2 is on the acidotic side of normal, 45. And then the PO2, did I tell you that it's about 10 millimeters mercury lower than arterial blood?
I wanted to ask you, sorry, I don't know, can you hear me?
Barely.
Oh no, maybe I'll type my.
You're going to type it? Okay. So capillary PO2, it's not very accurate. Again, it's a mixture of arterial and venous blood. You can estimate arterial from it by adding about 10-4 to the number, and that'll give you an estimate of arterial blood, but it's better to just go by your pulse ox saturation rather than looking at capillary PO2. Should we memorize the bottom portion of the PowerPoint? So by the bottom portion, you're talking about possible acceptable values with these. No, it's not a test question, if that's what you mean. So no, you don't have to memorize it. What is interesting to note is with chronic babies, they don't try to get the pH into normal range. Even for a capillary blood gas, they'll accept acidotic pHs. As long as the pH is greater than 7.25, then usually ventilator changes are not made or intubation is not determined as long as pH is greater than 7.25. All right, so this is what we did not talk about, I'm pretty sure. So when drawing capillary blood from a neonate, where do you draw it from? So I will type it in the chat. You draw it from the heel area, but it has to be a very particular place on the heel. It can't be directly on the back of the heel because you're going to damage developing bone. It has to be on the side of the heel, the lateral side of the heel. So I'll type that in. So the best place is drawing from the lateral side of the heel. It says avoid the medial side due to the tibial artery, and then avoid the direct back because of causing bone splinting. And for pediatrics, just all I have is use their finger. It doesn't say which one. So when drawing a capillary stick on a pediatric, sticking like the third, fourth, and fifth finger is best. I think it's because the nerve is more sensitive than the pointer finger. But I'm not really sure. You don't stick the thumb, you don't stick the pointer finger, you stick 3, 4, and 5. So if you have a question or a scenario on the NBRC, and it says you go to draw a capillary blood from a neonate, and you notice that there's inflamed and swollen tissue on the lateral side of the heel, what should you do? Should you draw the blood gas anyway? Should you stick the medial side, or should you stick the posterior part of the heel? So none of those would be good choices. So if there's swollen, inflamed tissue, don't stick that area. There's going to be a lot of fluid in the interstitial space that's going to come into the capillary blood, and it won't be accurate for one. And if there's an infection, you're just going to aggravate that area. So if it's swollen, inflamed, don't stick that area. Right, then on the procedure, it says arterialize the skin by wrapping in a heel warmer for 5 to 7 minutes. So if you have the area warm, you're going to have more arterial blood flow to the area, and it's going to give you a more accurate sample. It says to puncture the cutaneous layer of the skin. So we spoke about where you would puncture. And then it says collect free flowing blood into a capillary tube. So to get the blood to flow freely, you have to squeeze the heel.
Is this, sorry to interrupt, is this similar to when you do a, like a stick to do a blood glucose check?
Yes.
Okay.
Yeah, blood glucose with the newer meters, you don't need much of a sample. But to run capillary blood in the blood gas machine, it needs to fill the capillary tube. Probably still a small amount. A rough guesstimate, maybe like 5 or 6 good drops of blood will fill the capillary tube. So when you need to squeeze the heel. So you kind of wrap your hand. I don't know if this picture displays it very well. but wrapping your hand around the foot and the ankle and kind of squeezing them together will push blood into the capillary tube. And then also the way the picture looks, doesn't it look like the capillary tube is being held in a downward angle? But when you're sticking the heel and you're drawing the blood, you have to have your capillary sample at a little bit of an upward angle, not a lot, but a little bit. Otherwise, air bubbles come in. So you get a little blood, an air bubble, a little blood, and you can't have any air bubbles in a capillary tube or it's going to mess up the machine. And then you have to put it through a cleansing to try to get rid of all the air bubbles. So you can't put any air bubbles in the capillary tube. And the way to avoid that is to have the capillary tube angled upward a little bit. Blood will get drawn into the tube, but not air. So I'll put that in the chat. So I wrote, when drawing capillary blood, keep the capillary tube angled slightly upward. This will prevent air bubbles from going in. All right, so that's what I had on that slide. As far as accuracy of the sample, it says if the neonate is crying, it's going to affect the values. Yes, especially oxygenation, because when they're crying and they stiffen up their chests and they're crying, you don't have good air exchange occurring during their crying spell. It affects the O2 for sure, and it can also affect the CO2. So if they're, sometimes when they cry, it's a very long exhalation, and then they finally take a breath and it's another long exhalation, and they kind of mess up the CO2 a little bit. So if you're asked if the neonate is crying, does that affect the accuracy of a capillary blood sample? The answer is yes. Air in the sample, go ahead.
I'm sorry, Yvonne, I was going to ask you, if I was crying, would that affect the accuracy of my blood?
Say it again.
If I was the one crying, would that affect my blood sample?
So an adult crying, would that affect an adult's? Yeah, I would think a little bit of a respiratory alkalosis with crying with the adults. And then too much squeezing will cause more venous blood to mix with the sample. So aggressive squeezing of the heel is going to affect accuracy.
Yvonne, can I ask you a question for that one?
Yes.
In Joe D, like on Friday, they were saying how they were getting a lot of like excessive potassium readings, like too much potassium from squeezing the foot. So I did a CBG, a few CBGs on Friday, and my RT's like, don't squeeze the foot too long because it'll read a high potassium. So do you know why that would be?
Yes. There's a lot of potassium inside of a cell. And when the cell ruptures, a lot of that potassium is leaked into the blood plasma. And then the blood gas machine will register that potassium.
Okay, thank you.
Yeah, so that's the connection. Yeah, it's good that you're having all these experiences. So this lecture material makes a lot more sense. All right, so the kits that you see for drawing capillary blood might be what you're seeing here. And then again, it might be something different. So inside the capillary tube, there is dry heparin. And to mix the dry heparin with the blood, it helps to put a little piece of metal inside the capillary tube. And then this will also, not only will it distribute the heparin, it will also connect to any blood clots and get the blood clots out. So you put this piece of metal in there and it's called a flea for some reason. So I said, you put a piece of metal strip, or they call it a flea, inside of the capillary tube. You move it around by using a magnet. So this blue thing in the other picture is a magnet. And as you move it back and forth across the capillary tube, it'll move the piece of metal. And the reason for that is to get rid of blood clots. So the metal strip, or the flea as they call it, will catch any blood clots that may have formed, as well as it moves the dry heparin into the blood. At what temperature should the blood gas capillary tubes be stored at prior to analysis? And here it's saying room temperature. So with arterial blood, we talked about if you're going to be away from a blood gas machine for 30 minutes or more, it's best to ice the sample until you can run it. For a capillary blood sample, it's saying to transport at room temperature. Let me see if I have anything in my notes. My notes say up to 15 minutes. So it's okay to keep the capillary sample at room temperature for up to 15 minutes. All right, so that was it for capillary blood and sticking the baby to get capillary blood. Do you have any questions on that before we move on? No, good to go? So with apnea monitoring in the neonatal ICU, all of the neonates are monitored for apnea. But what about when babies go home? Then an apnea monitor, if it's indicated, will be brought by, usually a home care company will bring the equipment to the home, and then the baby is set up on the apnea monitor at home. So if the baby's having periods of apnea like greater than 20 seconds, that's pretty long, then they need an apnea monitor. How does an apnea monitor work, you ask? Well, let me tell you. So when breathing in and out, the chest expands. And when the chest expands, if there's a belt wrapped around the chest, it's going to notice this change in the thoracic movement, and it registers that as a breath. So Yeah, it just says apnea monitors measure chest movements and heart rate. So it also has an electrode that picks up the heart rate. The alarm is set to go off if the infant stops breathing for 20 seconds or if the heart rate slows to less than 80 beats per minute. This is a picture of a belt that goes around the chest and it picks up breathing movements. And you also see the electrode for picking up heart rate. Let me put that in the chat. Do you see what it's calling the apnea monitor? It's called impedance pneumography. So that sounds like something they would do to you on the national exam. Instead of saying an apnea monitor, they will say the infant is being monitored by impedance pneumography. What do you recommend? So let me put that word in the chat. Impedance pneumography. Okay, if a baby is at risk for SIDS, then you would recommend that they have an apnea monitor at home. If they've had one or more apparent life-threatening episodes, an ALTE, and then it gives you what a ALTE is. So period of apnea, cyanosis, choking, or lifelessness that requires stimulation or CPR. If that is observed, then the baby needs to be monitored for apnea, and you would recommend that they be put on an apnea monitor. How would you know when to tell or when to recommend that the apnea monitor be discontinued? There needs to be 2 months free of any events, for one. So no episodes of apnea, no heart rate going less than 80 per minute. And then a follow-up pneumogram is indicated. And a pneumogram, I don't know why you would need a pneumogram if you're continuously monitoring as a pneumogram. But that's what the textbook said. Follow up with a pneumogram after 2 months free of events. Right, so that's it for apnea monitor. And babies and pediatric children will have transcutaneous monitors. So transcutaneous monitors stick on the skin, and there's a picture coming up that show what it is. And it has electrodes inside that can measure carbon dioxide level, and carbon dioxide level pretty close to arterial blood. Also measures oxygen level, not too close to arterial blood, but at least you can use it for trending. So here it says an electrode is placed on the chest or on the abdomen of the neonate. The electrode reflects arterial oxygenation and arterial carbon dioxide level. So when you're talking about the reading that you're getting, it's going to be capital T, little c for transcutaneous, and then the gas that you're monitoring. So TCCO2 is transcutaneous level of carbon dioxide. So carbon dioxide perfuses tissue more readily than oxygen. Therefore, the carbon dioxide readings usually correlate more precisely. Meaning that if you draw an arterial blood gas and you look at the CO2 from the blood gas compared to the CO2 you've got on your transcutaneous monitor, they're going to be pretty close to each other. It's used for trending rather than, what do I want to say about trending? I guess for trending, because the values are not exactly like they are in arterial blood, to make a decision based on transcutaneous CO2 or transcutaneous oxygen, not a good idea. You'll probably end up drawing an arterial blood sample, even though you've got the transcutaneous monitors on. So why bother putting the transcutaneous monitors on? And the answer is it can be used for trending. So if you see a big increase in the CO2, that's a signal that maybe the baby's not ventilating very well, something's going on in the lungs. So it's good for trending, but it's not looked upon as being really accurate. So inside the electrode that you stick on the chest, it's got oxygen and carbon dioxide electrodes. The name of the oxygen electrode is a Clark electrode, and the severing house electrode is what they call the carbon dioxide electrode. So this picture is showing the transcutaneous monitor on the infant's chest. It looks like it's right over the sternum. And I know you're supposed to avoid any bony areas because you don't get good readings if you're over a bone, but it looks like they've got it right over the sternum. So anyway, in order to get arterial blood to flow to the surface of the skin has to be warmed up. So there is a little heater inside the electrode. It warms the skin to about 43 to 44 degrees Celsius. What is that in Fahrenheit? Like 102, 103 degrees Fahrenheit on the skin. And that can actually burn the neonate skin. So you have to change sites every 4 hours. You got to move it to different places just to avoid those burns. What else did I want to tell you? I'm going to give you a sample in a second. So it says to calibrate, first calibrate to room air. So before you put it on the baby and you do a calibration, you hold the electrode into room air and you read the amount of oxygen in room air. And here it's left blank. Do you know how much oxygen is in room air?
I hope we do, Yvonne.
In millimeters mercury, not percentage. Right, how can you figure it out? Do you know how to figure out what the partial pressure of oxygen is in the atmosphere? It is 21%, but what is the partial pressure reading? Yes, very good. I love your honesty. That's pretty cool. You Googled it? Okay. So yes, 159 point something or 160 torr. So when you're holding the electrode up to the room air, it should read 159, 160 torr. You need to know that because you're going to come across a troubleshooting question. It's going to say the electrode is showing, it suddenly starts showing a PO2 of transcutaneous PO2 of 160 torr. What could be the problem? What could be the problem if it's reading 160? The answer is it's reading room air. Probably the electrode became unstuck from the chest and it's now reading room air. Okay, so we'll move on. I mean, you also use a calibration gas. It's as part of the monitor for calibrating the CO2. All right, now I want to give you an example. Can I write with my annotate text? Let's do it like this. And make you guys go away. We have a 7.35 pH. The PaCO2 from the blood gas, 60. PaO2 is 70. And then okay, so I gave you a blood gas, 7.35, the CO2 is 60, PaO2 is 70. At the same time, we look at the transcutaneous monitor. It says the transcutaneous CO2 is 60 torr and the transcutaneous O2 is 60 torr. Is there something wrong with the transcutaneous monitor because it's not reading the correct oxygen? Very good. So there's nothing wrong with the transcutaneous monitor. It's just that oxygen doesn't diffuse through the skin as easily as carbon dioxide does. Carbon dioxide is a very diffusible gas. Oxygen, not so great. So that's why the O2 is lower on the transcutaneous monitor. Good job. Okay, and then another question. Let me put it down here. So if the transcutaneous O2 drops to 50 millimeters of mercury, so what was it? 60. Now it drops to 50 millimeters mercury. What would you expect from the arterial PaO2? So if we're showing the transcutaneous is 50, and we know that it's trending with the blood gas, what would you expect? Very good. So 60 millimeters mercury. So 70, when the transcutaneous monitor said 60, our blood gas said 70. So we know from comparing those two that the arterial blood is about 10 torr different from each other. So if we're looking at our transcutaneous and we see 50, we can pretty much assume that the arterial blood is 10 torr better or higher, and it would be 60 millimeters mercury. All right. Did I go backwards? Wait a second. All right, so for placement, you can put it on the chest, you can put it on the abdomen, avoid bony areas. You don't get good perfusion over bony areas. Accuracy affected by skin thickness and fat. And that's why it's not used very much on adults. If it is used on, I've seen it on the bigger kids in the PICU, especially when they're on the oscillator and you want to know if you're not ventilating suddenly, since you can't really listen to breath sounds and notice a difference. It's nice to have the transcutaneous monitor on. So on kids, they're going to put it on the inner part of the arm. Hold on, there's a picture. So on the inside of the arm, the skin is thin, and that's a good placement for it. Also inside of the thigh. So inside of the arm and inside thigh. Okay, and then last we have some information about pulse oximetry, which is a review for you guys. A pulse oximeter has 2 wavelengths of light. Yes, Summer, I did. So inside the arm on pediatrics, also inner thigh on pediatrics. Should I put that in the chat? Yeah, inside arm and inner thigh. Okay. All right, with pulse oximetry, it has 2 different wavelengths of light that it sends out. One wavelength of light will get absorbed by hemoglobin that has oxygen. Another wavelength of light will get absorbed by hemoglobin with no oxygen. And we call the deoxygenated hemoglobin different names. It's called reduced hemoglobin, HHB on the blood gas. It's hemoglobin with no oxygen. So that absorbs different wavelengths of light. From that, the pulse oximeter will set up a percentage. Fetal hemoglobin absorbs the same, very similar to the same wavelength of light as adult hemoglobin, so you don't have to do anything different with a pulse oximeter for babies or preemies or neonates. With movement, the pulse oximeters are getting better and better with this. Like the newer technology knows how to filter out movement and still give you pretty accurate readings. And sometimes the movement of the body causes a lot of artifact. So don't always trust in the readings. Make sure that you check. One of you guys are sharing a story with me where the nurse called you because the stats were reading 80% on the patient. And you go over and the pulse ox wasn't even on the patient. So yeah, you want to make sure that you have your sensor on correctly and that it is picking up. So don't always believe what you see on the monitor. Another good way is to make sure that the waveform and the heart rate are lined up, meaning that it's reading the pulsation of blood that comes into the finger. I have a question. My question is, where is the pulse ox sensor placed on a neonate? Wrap it around the finger or the toe. Chris says the forehead.
I see it on their toes mostly in Broward.
Where is it placed on what kind of patient?
A neonate.
Around their foot?
Yeah. So it gets wrapped around their entire foot. Because they're so tiny. Can it go around the toe? Sure. Yeah, if you can get around the toe, that's another good spot for it. So Chris, on the forehead, when you take a pulse ox probe and open it up and you stick it on the forehead, it's always going to give you 100% O2 saturation. So what happens when you open up that sensor and you place it on the forehead, the sensor thinks all of the wavelength of light got absorbed and you're doing great and you have 100% O2 sat. And it's completely wrong. So
I
if
thought
you
they
ever
had
see it on-
special, I thought they had special like pulse ox sensors for neonates to go on the forehead.
And adults. So if you have one that's designed for the forehead, then yes, you can use that. But you can't take one that goes around the finger or the foot and put it on the forehead.
Right. Yeah, you
Oh.
got to make sure you have the right one, but
Yes.
Some of them have two sensors because some have the pre-ductus and post-ductus pulse ox.
that's right.
And where are those placed, Rachel?
I know one's on the foot. I don't know if both are. I didn't really pay too close of attention, sorry.
One's got to be on the right hand and the other one's got to be left, somewhere on the left side of the body. Like
I
the
think
right.
it's their left foot and their right like arm or something like their, I don't know. They're so tiny. Their feet are like smaller than Barbie feet. They're adorable.
Says Rachel, who absolutely hates working with babies.
I don't hate babies. I just don't want to have a baby. There's a difference.
Okay. So Chris, yes, you are correct. So one goes on the hand, the right hand only, not either hand, just the right hand. And then anything distal. So it could be the left foot, it could be the right foot. That's not going to make a difference. So it doesn't have to be the left foot. Because the left foot, the right foot are both being fed by the descending aorta, and that oxygenated blood is going to be the same. So whether it's umbilical artery, left foot, right foot, all three of those things are going to read the same. And those are all going to be post-ductal. As far as low perfusion, that can happen. If you have a patient that's really cold, maybe they're septic and they're shutting down and you're not getting good perfusion to the hands, and you put the pulse ox on, do you get abnormally low O2 sats because they're not perfusing? And the answer is no. You typically just don't get a reading rather than getting a low O2 sat. Does that make sense? I hear the nurses saying this a lot, not that I hear some respiratory therapists. The patient will be really cold and no, that's not what they say. The SAT is 88%, but that's because the patient is really cold. And that's completely not true. So when you're really cold and you don't have good perfusion to the finger, you're just not going to pick up a pulse, and you're not going to get a waveform, and you're not going to get a reading. It's not like your readings are low because you have poor perfusion. Let me put that in the chat. Okay. So don't assume that a low O2 sat means the patient has poor perfusion, because it doesn't mean that. You just won't get a reading if they have poor perfusion. What is a safe oxygen saturation for a neonate? I think I've given you a couple of variations. I think 85 to 95 was one of the variations. And then again, I'm super lenient on the exam. So if you say a normal O2 sat for neonate is 85 to 95, I'm good. 88 to 92, I'm good. 88 to 95, I'm good. And then this slide is meant to talk about how when you get a blood gas and you compare O2 saturation from the blood gas to the O2 saturation from the pulse oximeter. Pulse oximeter reading is typically higher by 2%. Why is that? So this slide's supposed to shed some light on that. So lab co-oximeters have several different wavelengths of light. And just to explain again what a co-oximeter is, a co-oximeter directly measures the different types of hemoglobins. It doesn't estimate it based on an equation, it's an actual measurement. So like the ABL 90s that you're using will have a co-oximeter built into it. It measures hemoglobin with oxygen, hemoglobin without oxygen, methemoglobin, salt hemoglobin, carboxyhemoglobin. There's a couple others that it'll measure directly, the percentage of each of those hemoglobins in the blood gas machine. I don't know if usually this example confuses everybody. So how about if we just skip through to the conclusion? So I wrote a pulse ox O2 saturation typically reads, oh, this, pretend the S is not there, 2% higher than blood from the blood gas machine. And the reason is it's different fractions with a pulse oximeter, only looking at hemoglobin with oxygen and hemoglobin without oxygen. From that, it sets up a percentage. Looking at a co-oximeter, it's looking at all of these different percentages and then reporting oxygenated hemoglobin as one of those percentages. And that's why you get about a 2% difference between them. Oh, that was it. So what is more accurate? Which is more accurate for the oxygen reading? Is it the pulse ox or the blood gas machine with the co-oximeter?
Blood gas machine.
Yes, that's it. All right, guys, that's all I have to say. Do you have any questions? Are we being tested? On what PowerPoint are we being tested tomorrow? For the PFT final, Summer, is that what you're asking?
Oh, never mind. My brain is not thinking right.
Okay. Yeah, for the PFT final, I posted a review, so you can go through the review. And it is cumulative, so I would take a look at the review that I posted. Okay. Sounds good. All
Thank
right,
you,
if there's no
Professor.
more,
Thanks, Yvonne.
I have a question,
you're
Yvonne, real
welcome.
quick. And then are we switching over to our new class tomorrow? Wait, we pick up one extra class tomorrow, don't we? Or does that start next week?
Next week. So we still have advanced equipment. We have to finish up on high frequency ventilation tomorrow, and then you have your final. And if everybody wants to take the final first, then it would have to be a unanimous decision. Otherwise, the final takes place at 3:30.
Thank you.
You're welcome.
All right, I'll see you tomorrow.
See you tomorrow, Chris.
And then just because I had to leave early, but was there anything that I missed during lab after I left, or?
No, I just had everybody set up the ventilator one more time with a motor ventilation,
Okay,
and then we left.
okay, thank you.
You're welcome.
Bye.
Bye.